Thank you for joining my presentation on Airway Pressure Release Ventilation, commonly known as APRV. My name is Terrence Shenfield, and I've been an education coordinator at a major trauma center for over 30 years. I also have extensive experience with APRV. One of the fellows that came into our hospital studied under Dr. Hibachi directly, and she sort of took me under her wing and showed me how APRV works. There are other names for APRV. For example, some people call it bi-level. The other manufacturers may call it bi-vent, and some even call it biphasic, and some even call it duopap. So it's a host of names for them, and there are little subtle differences, but I wanted to teach you some of the basics of this, and I really want you to understand that APRV works great for ARDS. So I'm going to show you a case study of ARDS just to break you in to understand how everything works. So what is ARDS? ARDS, commonly known as Acute Respiratory Distress Syndrome, is an inflammatory process to the lung. Basically, there's some kind of predisposing thing that happens to your lung that ends up having the patient going into acute respiratory failure. On x-rays, you'll see bilateral infiltrates. You have to determine that there's absence of left ventricular function, because what happens is you get a lot of edema, and you're wondering, is it the ARDS or is it a left ventricular failure? So you have to do a difference between each two. Another thing with ARDS is that you got to look at the PF ratio. A PF ratio less than 200 is ARDS. A PF ratio less than 300 is acute lung injury. So they are different. And also they've been calling ARDS different levels based upon the PF ratio. So there's a couple of different definitions. But for our purposes, if you have a PF ratio less than 200, you have acute onset of respiratory failure, you have bilateral infiltrates, and you ruled out left ventricular failure, you have ARDS. If your PF ratio with all the same scenarios is less than 300, you have acute lung injury. The management is very similar. As I was mentioning, acute lung injury has the same criteria of ARDS, but the PF ratio is less than 300. Now, I also wanted to tell you that some people determine the severity of lung injury. They drop the name ALI, they say ARDS, but they actually say it in three different categories. One is mild, where your PF ratio is anywhere from 200 to 300. The other one is mild to moderate, where your PF ratio is 150 but less than 200. And then moderate to severe is a PF ratio less than 150. Different school of thought, same thing, you got ARDS, and, based upon your PF ratio, they can reclassify it even further. But ALI, to me, is a common term used, and you could use it interchangeably with these mild to moderate, and moderate to severe. ALI, or ARDS, is an acute inflammatory condition of the lungs due to some underlying disease process. And when you think about ARDS, you could either think as primary ARDS or secondary. Another word is direct or indirect. There are two different types, and we'll get a little bit more into it on the next slide. Primary ARDS occurs in about 70 to 80% of the case. The most common reason for getting ARDS is that you have a pneumonia, where 40 to 50% of the cases are a result of that. You could also get ARDS from aspiration of toxic gases. You could get ARDS from pulmonary contusion. Let me tell you about pulmonary contusion. I worked at a major trauma center. There was a lot of motor vehicle accidents. There was a lot of gunshots. There was a lot of, beatings of patients, with bats and stuff like that. And, you think they come in with an injury, a trauma, and they ended up going to ARDS. Also, inhalation of toxic gas, and we all heard the term near drowning. So patients who are drowned, sometimes they wash out all the surfactant in the lungs, and as a result, they go into ARDS. So these are cases of direct or primary injury that occurs in 70 to 80% of all the cases of ARDS. Indirect or secondary injury of ARDS typically is caused by a systemic inflammation that activates all these pro-inflammatory mediators and cytokines. So what you have is you have systemic inflammation, and because of this inflammation, all these pro-inflammatory mediators are released. It could be as a result of an infection. You could be septic. It could be from tissue ischemia, from necrosis or pancreatitis. It could be from tissue damage, like I mentioned earlier, from trauma. It could be from cabbage. It could be post-op cases. And there's some research out there on COVID-19 causing like ARDS symptoms, and it could be as a result of this systemic inflammation. That's a whole topic in itself. But understand there are two different types. There's primary and there's secondary. Secondary is more related to systemic inflammation and the generalized activation of these mediators that cause all this damage. Now, there are some independent risk factors with ARDS, and some of them are old age. You know, the older you are and you have to have some underlying medical condition, the greater likelihood you could go into ARDS. Also, patients who have infections. If you have a systemic infection, you could go into ARDS. And then neurological disease. This is another case where we were talking about weaning patients from neurological ICUs. These patients could go into ARDS. So these are some independent risk factors that go along with patients who are predisposed to getting ARDS. So let's talk about the clinical picture of ARDS. Basically, a patient will have an acute shortness of breath. So in other words, they come into your hospital and they're doing fine. Their saturations are 98% on room air. Shortly after that, they start desatting, and you put a nasal cannula on them. Then eventually you go to a non-rebreather. And this all takes place in a very short period of time, sometimes overnight. This is the hallmark sign of ARDS, when you have acute shortness of breath. You have cyanosis. Obviously, when you're short of breath and you have cyanosis, you're going to be tachypnic. Also, you have shortness of breath, dyspnea, and you end up getting crackles. Crackles comes from alveolar flooding of fluids. So the clinical picture is these things listed above, and you should be aware what you're looking for is an acute change in the respiratory status of the patient. It's not gradual, it's acute. ARDS typically is in three phases. One is called the initial acute phase, the second one is the second phase, and the third one is the third phase. It's right on the paper. So whatever the case is, during the first few days, what you end up getting is pulmonary edema secondary to capillary leakage. So what you have to understand, when you have pulmonary edema, your oxygenation status is going to deteriorate. And that is when I told you see an acute change in oxygenation status. You have to rule out that it's not cardiac in nature. So it's not cardiac pulmonary edema. It's actually edema caused by inflammation of the lung. So the first part, in the first few days, you end up getting extensive pulmonary edema. You end up having poor oxygenation. You rule out that it's not cardiac in nature. During the second phase, which is the most damaging phase, is the inflammatory stage. And the inflammatory stage means that as our body responds to any kind of insult to it, it releases all these cytokines that can, they're trying to cure you. I mean, this inflammatory stage is a good sign, but except it is really too much. So all of these interleukin-6, interleukin-8, tumor-necrosing factor alpha, interleukin-1 beta, all of these cytokines are released in the body, which further creates more havoc in your lung. And then eventually, in the second phase, in the first and second weeks of getting ARDS, this organization of edema turns into hyaline membranes, which actually creates that honeycomb appearance in the lung. Third phase, after all this inflammation keeps on going, you end up getting fibrosis. So when you get fibrosis, your lungs become very stiff, you have poor compliance, you have poor oxygenation, and that's when you're probably intubated during the second phase, and by the third phase, you just maintain. This is part of the strategy because of this fibrosis, because of this inflammatory mediators being released in the body. That's where you want to do gentle ventilation. Absolutely, this patient's going to be intubated. And when you put them on the mechanical ventilation, you really want to use a good strategy with them. And, the ARDSnet strategy is a great tool. They did a lot of research like that, but APRV is a great tool for this particular phase. So you really want to, if you suspect someone's going into ARDS and you recognize the signs like pulmonary edema, no cardiac insult, you're looking at inflammatory responses with cytokines being released in the body, you're looking at poor oxygenation, you want to jump and put patient on APRV early. You don't want to wait to the third phase when they got fibrosis. If you recognize that compliance is going worse day by day, and then you say, something's going on here, and their oxygenation, the PF ratio is going down, you got to do something like an ounce of prevention is worth a pound of cure. So during the second phase, when you recognize this happening, this is when you want to implement a low tidal volume, high PEEP strategy, or you want to use APRV, which we're going to get to. So the whole point of me educating you on ARDS now is that you understand how to utilize APRV at this point. And if you do, you increase the mortality, you actually decrease the mortality of the patient. The patient has a better likelihood of surviving if you jump on it. When do you want to jump on it? As early as possible and no later than the second phase. When you start seeing these things happen, you want to intubate the patient, you want to manage them with a low tidal volume, high PEEP strategy, or you want to use APRV right from the get-go. So why do you want to intubate them? At this point, during the second phase of ARDS, this is when you're going to see interstitial and alveolar edema. You're going to have flooding. You're going to have those alveolars are going to be full of fluid and debris, and then you're not going to oxygenate well. You're going to have what is known as increase in extravascular lung water. You're going to have all this edema. You're going to have pitting edema. You're going to have increased stiffness and weight of the lungs. Because of all the fluid in the lungs become very stiff. As a result of that, you end up getting what is commonly called compression atelectasis. All that fluid and the heaviness of that fluid pushes down on the alveolar, and then the alveolar become collapsed, and that's caused compression atelectasis. You're also going to see a reduction in compliance. You're going to look at your compliance ratio on the ventilator. All ventilators have compliance settings, and you want to trend that. You want to look at compliance. You want to see how it's getting worse day by day, and then you want to do some kind of intervention. Also, you'll see a decrease in functional residual capacity, which will impact oxygenation, and you're also going to see an increase in intrapulmonary shunting, which again compromises oxygenation status. So compression atelectasis, reduction in compliance, decrease in functional residual capacity, all of these things make the patient really, really sick. Because of the compression atelectasis, this is a lot of times when we prone patients. When we prone patients, we make gravity work for us in the other way, but we're not necessarily talking about proning, we're going to talk about APRV. As ARDS progresses, we end up what is known as fibrosing alveolitis. Basically, our lungs become fibrotic in nature, they become very stiff, lung compliance is reduced, hypoxemia persists. Sometimes these patients could get pulmonary hypertension, and this could work its way right into right heart failure. Full resolution to patients can be anywhere. So if someone survives ARDS, which the mortality is around 50%, but if someone survives it, they have some kind of lung impediment up to almost 6 to 12 months. Sometimes lung function will return to normal, but a lot of times these patients, their lung function doesn't return to normal. But resolution is really long, like 6 to 12 months, and mortality is up to 50% in these patients. So the best way to manage this, to decrease the mortality, is to utilize some really good strategies. They got the insult, they got ARDS. So the question is, you don't want to make it worse. And what you want to do is you want to use lung ventilation that really optimizes high PEEP, low tidal volume, or you want to use APRV on these patients. So the diagnostic workup for ARDS consists of the medical history and a chest x-ray and a blood gas. I should have put a blood gas there. But in regards to the medical history, you want to know what caused this. Do they have an underlying infection? Do they have breathing in some toxic gas? What's going on? Why did they get this? Do they, did they have pancreatitis? What is going on? Do they have chest trauma? What's going on? And then, the x-ray, you want to see the bilateral infiltrates, and an ABG will tell you, what your PF ratio is. So these are the basic diagnosis workup for ARDS. This is a typical x-ray of an ARDS patient. And some of the things you want to look at is the ground glass opacification. Basically, you see this like honeycombing area right here. And, there's a lot of white out here, so you can imagine this lung is really not doing very well with oxygenation status. That is the typical findings with this, and you should be aware of this. More about the diagnostic workup. Remember, you have to determine whether the heart, you don't have left ventricular dysfunction. So how to determine that is done with an echo or a PA catheterization. You need to show that the pulmonary capillary wedge pressure is less than 18 millimeters of mercury. If you show that the pulmonary capillary wedge pressure is less than 18, that rules out there's any kind of left ventricular dysfunction. And then if the PF ratio is less than 200, you have marked hypoxemia. In other words, this occurs very quickly. Typically, the response to these patients, when a patient becomes hypoxic, they want to breathe more. They get, their shortness of breath, they get all these concerns, and they're having a hard time breathing. So what they do is they hyperventilate. And when you hyperventilate, you end up getting hypocapnia. So in other words, your ventilatory drive increases, you're breathing because you're nervous, your anxiety, you can't breathe, and eventually you tire out. So if you go from hypocapnia to hypercapnia, and at that point, that's when you get respiratory acidosis, and then you need to be intubated to maintain your ventilation. As I was telling you, your ABG, if your ABG is less than 200, you have ARDS. If it's less than 300, you have ALI. You can see that initially you will have hypoxemia, and you also have hypocapnia because of anxiety, and eventually you're going to go into acidosis. So the management of ARDS. Sometimes you might want to start with non-invasive ventilation. It really doesn't work very well, but some people want to use NIV at first when they find the patient's in respiratory distress. You basically got to be fully conscious at this point. You got to be a cooperative. You need to be hemodynamically stable. You need to be able to take some decent breaths, and you have to make sure you're not fatigued. Here's a very key point. If you put someone on non-invasive ventilation and they're on NIV for 1 hour and they do not, their blood gas doesn't improve, that their PF ratio is less than 200, it's not working. Intubate. The longer you delay intubation, the greater likelihood of increasing their mortality. So the point is this: yes, give NIV a chance. See if non-invasive ventilation works. If it doesn't work, in 1 hour, intubate. Don't delay. All the evidence shows that the longer you wait to intubate, and the more you keep them like in this state, the greater likelihood they're going to die. The reality is that most of these patients are going to need some form of mechanical ventilation. Basically, when you get a blood gas that's not being corrected by non-invasive ventilation, you really need to intubate. There are complications to intubation. You have prolonged hypoxemia, you can aspirate, you can have misplacement of the endotracheal tube, and some patients even become hemodynamically compromised as a result of intubation. But most of these cases of ARDS, when the PF ratio gets worse and they don't respond to non-invasive, you need to intubate them. And we know what we're doing with intubation. So intubate them, stabilize them, and then we're going to talk about strategies to manage them on the mechanical ventilation. So let's talk about managing the patient on mechanical ventilation. So the patient failed non-invasive ventilation, so you decide to intubate, you have a successful intubation. Now, typically when we intubate someone, we would probably put them in assist control or SIMV to initially start, and we'll set up with a tidal volume based on their ideal body weight. You'll create a PEEP level that is effective. A lot of times these patients don't do very well, and because their compliance gets worse, peak airway pressures start increasing. So what happens is, you put them on mechanical ventilation, and before you know it, you're looking at the compliance, and the compliance is worsening, and then their peak airway pressures are getting worse. And then there's a thing called ventilator-induced trauma to the lung. So you don't want to really create this kind of damage to the lung, because that'll only exacerbate the patient. So what you want to do is then, to control the pressures going into the lung, you end up putting them on pressure control ventilation. And what this does is you can limit the amount of pressure to the lung, not to cause damage to the lung. The offset to that is if you keep the pressure lower, you're going to end up getting hypercapnia, because you won't be able to blow off all the CO2. And eventually your oxygenation status goes worse. So what do? You end up putting them on inverse IE ratio pressure control ventilation. So what does that mean? That means typically you have an IE ratio of like 1 to 2 or 1 to 3, depends on the type of patient. And when you do inverse, you start with a 1 to 1, and then before you know, you're 1.5 to 1, then you might even be 2 to 1. So when you have inverse IE ratio pressure control ventilation, and you have an IE ratio of 2 to 1, do you think the patient could be awake? Do you think they could breathe on themselves? No, they are just like flipping out. So what do you got to do them? You got to paralyze them or really deeply sedate them. So that's the negative aspect of inverse IE ratio pressure control ventilation. And there's typically a progression from assist control, the pressure control, to inverse IE ratio. Then all of a sudden you become desperate. And when you're desperate, you look at some alternatives. Then they want to put APRV on. Or they even actually did some studies using the high-frequency oscillator ventilator 3100B for adults, but that didn't turn out too good. They say, it's a great tool, the theory is good, it worked great for the babies, but it didn't really do this over to the adults. And eventually, when you get really up the creek, you're going to try ECMO. So the point, what I'm trying to say is, if you start with APRV early, you could avoid the assist control issue, you could avoid the pressure control issue, you could avoid the inverse IE ratio pressure control. APRV is like inverse IE ratio pressure control ventilation, and the IE ratio with APRV is more like 9 to 1. Remember, originally with pressure control ventilation, you have an inverse IE ratio of 2 to 1, but with APRV, it's 9 to 1. The beauty of APRV is that you do not need to sedate the patient. You do not need to paralyze the patient, and the patient could spontaneously breathe on top of that. So this is the transition from one mode of ventilation to the other. And if you just put the patient initially on APRV, you avoid a lot of damage to the lung. I am sure you might have heard of the ARDSnet Protocol. The ARDSnet Protocol, they did a study. When I first became a respiratory therapist, we used to give 12 to 15 cc's per kilogram of tidal volume. And if someone was in ARDS and they weren't really oxygenating well, we thought we should give them more tidal volume so they get a bigger breath. I mean, boy, were we wrong. Over time, we learned that lower tidal volume strategies work. Now, how do we know low tidal volume strategies work? And it all came from the ARDSnet Protocol. So, as a basic, you always want to keep the head of bed greater than 30 degrees. So that's not really what I want to talk about. Really what I want to talk about is tidal volumes and utilization of PEEP and keeping the plateau pressure less than 30. So let's talk about tidal. What's the ARDSnet strategy? Years ago, they did a study for ARDS patients. One group received a tidal volume of 6 to 8 cc's per kilogram, and the other group received 12 to 15 cc's per kilogram. So it was the normal tidal volume strategy, which was 12 to 15 at the time, versus a low tidal volume strategy. The difference is, with the low tidal volume strategy, they utilized PEEP. They used higher levels of PEEP early on, where the other group, they did, PEEP a little bit later. So they were doing this study, and very, very quickly, it was determined that the patients with the low tidal volume strategy had better survivability, better blood gases, better outcome, and they stopped the study immediately. So in other words, this study was supposed to go on X amount of time, say a year or two, and as a result of the findings, it was so drastically better to use low tidal volume. So the ARDSnet protocol basically uses a low tidal volume strategy of anywhere from 6 to 8 cc's per kilogram, and sometimes they'll use 4 to 6 based upon the condition. So if your PF ratio is less than 200, they're going to really use a low tidal volume strategy of 4 to 6. But if your PF ratio is anywhere from 200 to 300, 6 to 8. Also, you need to utilize PEEP. People are afraid of PEEP, but if someone needs a PEEP of 25, they need a PEEP of 25. A PEEP of 5 doesn't cut it. The whole purpose of PEEP is to keep the alveolar open, and so it doesn't collapse. And then ultimately, you want to keep your plateau pressures less than 30. So that's a little background on the ARDSnet protocol, which is really valid up to today's point. So, as I was telling you earlier, if you suspect someone has ARDS and during the early phase, maybe the second phase, that they're going into ARDS, this is when you want to initiate APRV. APRV was initially did some research back in 1987 by Dr. Stock and Dr. Downs, and they really were working with Draeger Medical at that time. And Draeger Medical is the one who came up with the term APRV. But as time went on, other manufacturers, McQuaid, Puritan Bennett, Hamilton, they wanted their version of APRV, and they call it a little bit different. Like McQuaid calls them bivent, Puritan Bennett calls them bilevel, Hamilton calls them dual PAP. But they're really the same mode, little nuances with it, but they are actually the same mode. So understand, the name doesn't mean nothing. It's just how you use the ventilator and how good you are as a therapist. So what is APRV? How does it work? APRV is a form of CPAP. So there's basically continuous positive airway pressure with intermittent pressure releases. Now, I know these are words, but I'm going to show you some graphical waveforms later that it's really going to make it clear. So let's just work with some definitions. APRV is like CPAP. It's continuous positive airway pressure with intermittent pressure releases. The value of APRV, it maintains functional residual capacity. The better your FRC, the better your oxygenation. Another benefit of APRV, it has a prolonged inhalation phase. So in other words, the IE ratio, and remember I was telling you the IE ratio with APRV is like 9 to 1. So it has a very long inhalation phase. Why is that important? Because it gives time for gas to diffuse into the alveolar. This long inhalation phase it actually promotes alveolar recruitment. It pops open collapsed alveolar. And then the second part of this is it has what is called a floating exhalation valve. And what does that mean? If you had inverse IE ratio pressure control ventilation, you cannot breathe above the vent. You are just like, you need to be snowed. You need to be paralyzed or sedated. But with APRV, because of the technology of this floating exhalation valve, you can breathe above this. When you breathe spontaneously, there's so much many benefits of this. I do a whole lecture on spontaneous breathing, but it's the whole benefit to it. And this is time cycle pressure release to enhance ventilation. So you're going to see the graphs things, but these are the basic. Increased FRC, prolonged inhalation phase, promotes alveolar recruitment, and you can spontaneously breathe. Beautiful, beautiful concept. So what are the advantages of APRV? First of all, you're going to use a lower pressure for a tidal volume as compared to tidal volume. In other words, if you were on assist control or SIMV, your peak airway pressures are going to be higher than with APRV. APRV works by a low pressure but a long inspiratory phase. Another thing is your minute ventilation is going to decrease with APRV. Why? Because you have less dead space ventilation, and we'll get a little bit more into that. Because there's lower pressures, it has less adverse effects on cardiac output and venous return. Also, you can spontaneously breathe through the whole cycle. Now, here's a very good thing. Numerous studies have shown that if you use APRV, you could decrease sedation use, and you really don't need neuromuscular blockade at all. So you don't need to paralyze patients. These are all really, really important things to make a patient better. So here are some of the disadvantages why people don't like APRV or any other modes on different ventilator. For example, APRV is a pressure control type of ventilation. So you initially set some pressures based on lung compliance. So lung compliance is not stagnant. It changes over time. As the patient worsens, their lung compliance gets lower. So that means you have to increase your pressures. So the problem is, just like with pressure control ventilation, you cannot set one setting on the ventilator on APRV and walk away and keep it there for the whole duration the patient be on mechanical ventilation. You have to make changes in pressure because volume changes with lung compliance and resistance. So the whole point of this is you have to be a little bit more interactive with the ventilator. Not crazy interactive. I mean, it's not like you're making 5 changes a day, but, you might make changes, once a shift, or you may not, or you might make a change once a day, or you might not make changes. But the bottom line is, because lung compliance and resistance changes with the patient, you have to be ready to change pressure settings on the ventilator, and that's due to tidal volume changes. Also, people just don't understand how to use it. They hate new technology. A lot of the residents, a lot of the fellows don't know APRV. When I worked there, I did so much education for everybody to learn APRV, and as much education I did when we were a university medical center, we used to have new residents come in, and they didn't know APRV, so it was a constant thing. So the point is this: people don't know how to use the technology, so they don't like it. They say, this is BS, but it's not BS. You got to learn it. Also, there's limited. At this time when I wrote this PowerPoint, there was limited research and clinical experience, but right now there's a lot more research on this. And also different terminology. When the different manufacturers call one biphasic, dual PAP, APRV, and you got all of these different terminology, it sort of makes it a little bit difficult for the clinician to manage it, because I'm very familiar with Draeger's APRV. I've never worked with a Hamilton dual PAP. Would I understand the concept? Absolutely. I would understand it clearly. But I don't know the terminology. So the fact that we got so many different terms, so many different names for the same thing, makes it confusing to the clinician. So one of the basic settings on APRV is setting your P high. And what is P high? Pressure high is set typically at plateau pressure. So plateau pressure is less than peak airway pressure. The advantage of that, you don't overly distend the lung. So what you need to do is get a plateau pressure from the patient on conventional ventilation, and that becomes your P high as a starting point. Also, you could do a +2 above your plateau pressure, but we'll get a little bit into that later. A PEEP valve on the expiratory limit of the ventilator prevents the patient from overdistension. So this is a very, very important part of how APRV works, that it doesn't overly distend the lung. So this results in lower peak airway pressures. A setting of time high, so time high inspiratory time, is anywhere from 4 to 6 seconds, and the point of this is improves oxygenation. So think about this. Your P high is your plateau pressure. That becomes your first setting. Your T high is 4 to 6 seconds. Think about as inspiratory time. And you say, how the hell does someone have a 4 to 6 seconds I time and be comfortable? That's because of the floating exhalation valve lets you breathe in and out, in and out, in and out without being distressed, and you don't need sedation. One of the key advantages of APRV is the recruitment of collapsed alveolar. Now, this is a CAT scan of a patient. Look at all this collapsed alveolar. How much do you think that is taking care of gas exchange? Even look at this side. Look at all the infiltrates. They're doing some oxygenation over there in recruitment, but they are not that pretty either. So the bottom line is APRV, because of the P high and the T high, pressure high and time high, it allows more time for collapsed alveolar to pop open. So what this does, it improves oxygenation and it optimizes ventilation, which is CO2 removal, all with a lower minute ventilation. As I was telling you earlier, APRV allows spontaneous breathing, whereas pressure control ventilation, inverse pressure control ventilation, or someone with, PEEPs of 20, it's a little difficult. Now, the benefits of spontaneous breathing are numerous. I have a whole PowerPoint, like I told you before, on spontaneous breathing and how it benefits a patient. But it's normal physiology. It mimics normal physiology. It's called the sinusoidal waveform. So in other words, as we breathe in and out, it has a sinusoidal type of waveform. It improves distribution of gas to dependent areas in the lungs. What do I mean by that? When you have collapsed alveolar and you spontaneously breathe, when your diaphragm pulls down, it indirectly pops open collapsed alveolar. And this is what I mean by dependent areas. It enhances VQ mismatch, and it also reduces the need for sedation. So this is a one slide talk about spontaneous breathing. It has everything. There have been numerous studies with spontaneous breathing benefits patients better than not breathing by themselves. So let me show you a graphical display of APRV. And I just want you to understand this. For example, your P high, right here, your P high is set to plateau pressure. Plateau pressure is always lower than peak airway pressure. So when you do conventional ventilation, you always have a peak airway pressure. That's the way it is. But with APRV, you'll ventilate at one pressure, which is called your plateau pressure, and that is called your P high. So P high is plateau pressure. P low is 0. P low is not PEEP. P low is allowing for gas to, so when the patient breathes in, and then, I just want to show you a little bit further. So P high is plateau, P low is always 0, and there are times when you might want to make it anywhere from 0 to 5. I'll get a little bit more into that later. But typically, P high is plateau, P low is 0. Now, a very important another setting is your T high. See this T high right here? That's your inspiratory time. So you have one pressure of 30, which say 25, which is your plateau pressure. Your P low is 0. And then another your T high, which is your inspiratory pressure, is like 5 to 6 seconds. And then your T low is typically 0.6 to 1 second. And what's the purpose of T low? That is for you to exhale gas. So what happens is the patient starts at this high pressure of plateau, which is your P high. They exhale, they exhale right here, and then they're back to the high level, and then on top of this, they're breathing. See them breathing? Spontaneously breathing. The little dips, they're spontaneously breathing, and then they exhale again. And then they come back and they do the whole thing over again. The advantage of this system is that your pressure is, the highest pressure you maintain is your plateau pressure, which is this level right here. So your ventilator will never go above that. And the purpose of this long inspiratory time, or your T high, is so that you could recruit collapsed alveolar and allow more time for gas diffusion. I got other pictures, but I just wanted to show you some basics right here. This is another example of spontaneous breathing on APRV, right? And this right here, this right here is your T low. And I have to show you a little bit more about that. But it's the idea is that you can spontaneously breathe on this mode, and this really benefits you tremendously. So how does APRV work? It works because it recruits collapsed alveolar. I could not say this enough. How does APRV work? It recruits collapsed alveolar, and it does a better job than conventional ventilation. So the whole purpose of APRV is lung recruitment, lung recruitment, lung recruitment. That's what you want. Another way of saying you don't want lung de-recruitment, you don't want lung de-recruitment, and you don't want lung de-recruitment, which occurs on conventional ventilation. So what are the indications for APRV? Acute lung injury, ARDS, and also acute restrictive diseases. You want to avoid patients who have COPD or hyperinflation diseases with APRV. It doesn't really work very, very well with that. It also works with the morbidly obese patient, which is another lecture in itself. But for this, what we're talking about, acute lung injury, ARDS, picture perfect. And as I was mentioning, you really don't want to use this on COPD patients, or you don't want to use this on bullous disease. It just doesn't work that well. But you may want to work on a morbidly obese patient. Why morbidly obese? Because when someone's morbidly obese, their abdomen pushes down on their diaphragm, and so their functional residual capacity is very low. And what that results in is poor oxygenation. APRV has a way of splinting open collapsed alveolar, increasing FRC, which does a little bit better. But that's another lecture in itself. Some of the benefits of APRV: spontaneous breathing. It also improves ventilation perfusion mismatches. It reduces pulmonary shunting. It uses lower peak airway pressure, which decreases ventilator-induced lung injury. It decreases the need for sedation, and because you work at lower pressures, it improves your hemodynamics. So these are some of the benefits of APRV. What are some of the potential risks? I mentioned this earlier before. Because compliance and resistance changes in a patient, just as normal, just as pressure control ventilation, you might need to make some adjustments with it. Not crazy adjustments. Think about it. You know, you're at the bedside, you're taking care of patients, you make these little minor adjustments, and then you improve the mortality of the patient. Also, there's a learning curve with this. You know, like some people, don't like to know what they know. They know they know pressure control, they know assist control, they know SMV, and now we got to learn APRV, and they say, I don't like it, because they don't know it. And once you know it, it's a really good thing. This picture is terrific. Let me show you why. What we have is we have normal assist control or SIMV, and then what we have, it's superimposed over with APRV. So let me show you what I mean. When a patient breathes on SIMV or assist control or pressure control ventilation, a breath, now look at this gray area. The breath comes in, right, and they get this peak airway pressure. They come down here, that's plateau pressure, and then they exhale to baseline or to PEEP, whatever your PEEP is. Then they do nothing, right? This whole period right here, they do nothing. And then they have another breath comes in, and they come up to peak airway pressure, which is right here. They come down here to plateau pressure. Then they exhale to PEEP, and then they come over here. So that is normal ventilation with assist control, pressure control ventilation, or SIMV. APRV is the blue. So what happens is you have the patient, the highest pressure they ventilate is at plateau pressure. So notice that the highest pressure is right here, is much lower than the peak airway pressure. What does that do? It prevents overdistension. So what happens is the patient inhales, right? And they have a long inspiratory time. And then the patient exhales, and then they come back and they inhale, and they long, and then they exhale. Remember, you could breathe spontaneously on top of this. But the point is this, that area is part of, it actually prevents de-recruitment. So what happens is you can recruit collapsed alveolar. With typical ventilation, it stops right here. So when the patient exhales, everything is de-recruited. But with APRV, you have all this blue area for recruitment of collapsed alveolar, and that is how it works so well. In other words, the amount of time that the alveolar stays open with APRV is tremendously better than conventional ventilation, and you use less pressures to do it, and you could spontaneously breathe on top of that. So that is how it works. So some of the advantages, it provides a continuous airway pressure to facilitate lung recruitment, lung volume, and oxygenation, because it gives you more time to recruit collapsed alveolar. It improves oxygenation. It facilitates spontaneous breathing, and it's a decreased need of sedation. So all of these factors make APRV very attractive. Now I'm going to teach you how to set up APRV. Now, I'm talking about a Draeger, but I imagine you could use any kind of ventilator that has APRV mode, and it may not be called APRV. It might be called one of those biphasic or dual PAP, whatever, bilevel. But whatever the case is, this is how you do it. First of all, you get a plateau pressure. That will be, you need a plateau pressure. And you need to make sure that the patient is on, when you get a plateau pressure, that the patient's on assist control, and that you don't have any kind of auto flow or any kind of enhancements to the flow. You really want a normal peak flow, and you really want to obtain a plateau pressure. And we do this on the Draeger ventilator by, we put the patient in volume mode. We have this feature called auto flow on the Draeger. I think it's called VC Plus on the Puritan Bennett. You don't want that on. And then you do an inspiratory hold for 10 seconds. That will give you your plateau pressure. Plateau pressure becomes P high. So now that you have your plateau pressure, that becomes your P high. You could use either that plateau pressure directly, or you could add 2 to it. So if your plateau pressure turns out to be 29, you could add 2 and make it 31. The maximum goal of P high should be around 35 centimeters, but I've seen it higher. A P high greater than 35 is needed with decreased thoracic abdominal compliance. What do I mean by abdominal compliance? If you have a morbidly obese patient, your plateau pressures may be higher because you're splinting open the thoracic cage and the abdomen, which is really big in these particular patients. But under normal patients, you really want to keep the plateau pressure under 35 or your P high under 35, but if you happen to have a big patient, you may want to increase it. Your next setting is your P low. When you set your P low to 0, this actually produces a minimal expiratory resistance, and this allows you to release the gases that are in your lung. This is how you remove CO2. So P low should be set to 0 because you want to allow for full exhalation. Your T high, your time, is normally set to 4 to 6 seconds with an adult. When you wean somebody, you will extend the T high and lower the P high. So basically, your T high is set to 4 to 6 seconds with an adult population. T low is a very, very important setting on APRV. It's the most challenging setting because it takes a little clinical intervention to figure out what it is. Typically, it's anywhere from 0.4 to 0.6 seconds, and most often it's around 0.5 seconds. The point of T low is to allow it actually, it's inadvertent PEEP. So T low, when you think about PEEP with APRV, what setting is appropriate for a PEEP? T low. Not P low. T low is PEEP. And what happens is you have to not let the patient exhale fully, and this is what you normally got to do to get best recruitment strategy, because if your T low is too long, you'll de-recruit. I'll show you more. This is an example of T low right here, this field right here, and this one is set to 0.7 seconds. You can see right there. So as the patient exhales, right, they exhale, 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 exhale. This is still exhale. Instead of letting them exhale to the baseline up here, you stop it from exhaling and you come straight up here. Bing. What happens is you are creating intrinsic PEEP. So T low is like intrinsic PEEP. And if you stop the patient from exhaling and give a whole new breath up here, what you do is you air trap. Air trapping equates to intrinsic PEEP. So setting your T low is very, very important, because if you set your T low too long, suppose instead of 0.7 seconds, I set it to 1.2 seconds, the patient will exhale the baseline and everything will be de-recruited. There'll be no intrinsic PEEP. So setting your T low is really important. So using your T low, these are lung de-recruitment strategies. You want to terminate your peak expiratory flow rate of anywhere from 50 to 75%, because this is how you will air trap what you want, and this is how you'll increase your intrinsic PEEP, which you want for better oxygenation. But you really have to understand how the waveforms work in regard to your T low. You really need to be able to truncate this at 50 to 75% of your peak expiratory flow. So understanding your peak expiratory flow regarding the T low is really, really important. So I wanted to further tell you more about setting your T low. When a patient exhales, see this area right here, right where that peak is? That is your peak expiratory gas flow. And whatever value that is, suppose that's 100. You want to terminate that flow right here, and then you give them a new breath. So when I say terminate peak expiratory flow, you first have to establish what your peak expiratory flow is, and you have to look at the ventilator graphics to understand this. Once you determine what your peak expiratory flow is, you adjust your T low that it truncates it at 50% or 75% of that value. That is how it works. I know it's kind of complicated, and I wish I spent a whole lesson how to do this, because if you set this wrong, you could all your strategies out the door. So in regard to APRV, what kind of blood gas adjustments you are? Think about this. To improve oxygenation, you have to increase your MAP. To improve hypercapnia, like suppose your CO2 is too high, you have to increase your minute ventilation. So these are the basics. No matter what knob you touched on the ventilator, if you want to improve oxygenation without touching the FiO2, you have to increase your mean airway pressure. And if you want to improve hypercapnia, the only way to do it is to increase your minute ventilation. Keep that in mind. To improve oxygenation, the first thing you need to do is increase your P high by increments of no more than 2. So the idea, if your oxygenation status is not that good, increase the P high by no more than 2 centimeters, and then you want to keep your FiO2 of equal to less than 60% and a SAT of greater than 93% or even 90%. It would be good on these patients. So how do you improve oxygenation? Increase the P high by no more than 2 centimeters at a time. So how do you decrease PCO2? You do a blood gas and the PCO2 is too high. The first step, there are 3 steps. Number 1, increase the P high to enhance recruitment. So again, you need to increase the P high by increments of 2. Step 2, you can increase the T high by 0.5 seconds increments and see what happens. Step 3, which you really don't want to do, but you could, is increase the T low to achieve a larger expiratory tidal volume. And you really want to watch that, because if you mess with the T low, you're going to mess with the oxygenation of the status. And that's probably exactly why you're doing what you're doing with APRV. So don't mess with the T low too much. So how do you wean from APRV? It's basically called the drop and stretch technique. Basically, you want to decrease the P high by increments of 2, but you want to increase the T high by increments of 0.5 seconds. The goal is to reach a CPAP level of 8 to 14, and once the P high is at 10 centimeters, then you could use automatic tube compensation. So basically, it's drop and stretch, decrease the P high by increments of 2, increase the T high by increments of 0.5 seconds to reach a goal, a CPAP level of 8 to 14. And once the P high is at 10, then you could use automatic tube compensation and wean the patient. So this is a picture of what it looks like graphically. So you have someone on full support here. You start weaning them, and then you're weaning them even more. So if you really look at this, you can see the height of the P high up here, right? And you can see that the height of the P high went down, but also the T high went up longer. And then eventually the P high went down even further, but then the T high time went longer and longer. If you look at this bottom feature, it looks like CPAP, right? That's all you are. You're on CPAP. APRV is a great tool for ARDS. You don't want to implement this strategy too late. You want to wait. You want to implement it during the second phase of ARDS. You don't want to make this a rescue ventilation, because if you make it a rescue ventilation, the patient's so far gone, and then when the APRV doesn't work and they die, they're going to blame APRV. This is BS. The point is this: implement it early. It's such a powerful tool. If you're going to use it on an obese patient, got to remember they're going to have compliance issues due to abdominal fat. So what you need to do is extend the T-low times, but you need to sort of do it prudently. So good luck with APRV. I hope you utilize, I hope you learned some more information from what I taught you. Here are some references on APRV. I mean, it's a great mode of ventilation to use, and I hope you understand it. I wish I had more time. I think I could actually spend a couple of hours on APRV and go over some case studies with you. Maybe I will. Maybe if you're really interested in what I'm offering, we could do more about APRV. But I thank you very much for joining my webinar.